Well, it's a bit of a bittersweet time to be here. I was blown away when Jorge contacted me to say I was awarded this, and I'm really disappointed that my close friend Michael cannot be here because of his unfortunate accident, but I wish him well, and I hope he heals quickly. So let's go through this. John Goldman, I think we should start in John Goldman with an anecdote, and I'm sure everybody who knows John has an anecdote, but here's one of my favorite ones. A number of years ago, I was giving a series of lectures in India, which is a favorite place for John to visit and also a favorite place of mine. And I was just about to start a lecture in Bangalore when the back door opens, and who walks in? John. Wow. He looks up into the back room, he says, I just happened to be in town, so I thought I'd come to your lecture. And for those of you who know John, the end of the lecture was always finished by him coming over to say what a great talk you'd done. And by the way, Jeff, can I have your slides? John was always great at taking your slides, but also giving the slides. And he was a gentleman, someone I always admired. Right back to the days when we worked together as transplanters, way before there was a TKI. It's not advancing. This one? All right. So why is this honor so special? Well, obviously my long association with John, but also my connection with Prague that makes this event. This is Prague, as many of you have seen, in particular. If you haven't had an opportunity to go down and visit the old city, it is beautiful. It escaped the ravages of World War II because it surrendered and the Russians overran it before the Nazis had a chance to do anything, but a beautiful city. But more than that, this is something many of you don't know, but if you find the statue in the lower left is a statue of this person called Yehuda Low, or the Maharal of Prague. There's his tombstone, and on the top right is a synagogue called the Alt Neu, or the Old New Synagogue. And below it is a creature that he supposedly created called the Golem, or a monster to save people. Why is this particular so special to me? Is I happen to be a descendant from the Maharal of Prague. So coming back to Prague is in some way coming back to some of my roots. So these are disclosures. And my involvement in CML over the years has evolved from first with allografting in CML, then studies with most of the TKIs were out there. I very much have been interested in adverse events, particularly in education of both physicians and patients as well as nurses. And I think that's been one of my most important considerations. So what do I think about it? I'm not going to sit here and talk about the things I've done, but one thing I keep hearing about is talking to patients. And I'm going to tell you the background this came from. As some of you may know, Passover is a Jewish holiday, and as you've already heard, I'm traditionally Jewish, which we commemorate the Exodus from Egypt in 1300 BC, so a long time ago. And there's an old graphic picture on the left and the Ben-Hur Charlton Heston rendition on the right. And it's very important. It's one of the three pilgrimage holidays, and the first night of Passover is something called the Seder, where we narrate the story. So this is an old medieval type picture of it, but some of you may recognize it as the one on the right. The Last Supper was a Seder. We're rendering the edition. And it got me thinking, because there's a part of it in there where we talk about how you talk to people. Now, it's all rendered in this something called the Haggadah, or it's a book of Passover, which lists all things. And it can be very serious, very gorgeous, like the one at the top and the second from the left, from the Sarajevo Haggadah, or very tongue-in-cheek, like the one in the bottom right, where you can see that the Hogwarts are the Donald Trump renditions. But what it is it talks about the four sons and how you just talk about Passover. And I think this gets to one of my interests, is talking to patients. And really what this says is there are four types of people. And you cannot sit there and talk to people the same way, because they're all different. What is relevant and important and understandable to one is not to someone else. And this is where I've had a bit of a discussion with particularly some of the patient groups, is you can't educate patients to say the same thing and ask all the same questions, just as you can't ask physicians to do it the same way, because every person you talk to is a little bit different. So this is just how it appears in one of these Haggadah books in various different renditions. And again, it can become tongue-in-cheek and very new. But here's the four patients. Use your imaginations. For the educated son, we have the people who I think primarily make up our patient groups. They're usually well-informed, involved, they're motivated, and they question appropriately. Then there's the evil son, or the people who are non-compliant, the ones who drive you nuts, who they come back into your clinic having not done what you want to do, not responding, don't care. And unfortunately, a lot of those are involved in the younger individuals, as we discovered from our pediatric colleagues, that treating CML patients as teenagers is horrible. And there's the ones who just sit there and don't say a thing. They're completely compliant, do what you want, but don't question anything. But there's also the patient who maybe doesn't know what to ask. Maybe something's going on, they don't know how to phrase it, afraid to ask you. We cannot manage these patients in the same way. They're all different. And I'm sorry, managing CML does not fit into a formula that any kind of guidelines, whether NCCN or ELN, can take. It's an individual. Dealing with the patient and not the disease is extremely important. And I think we need to be able to deal with that. I think as physicians and healthcare practitioners, we've become a nation of computer watchers and number people. We look at the numbers and we sit there behind a computer from a door on the phone and tell people what their their molecular reduction is. But we don't talk to them about what the impact of their treatment, whether they're doing well, not doing well, having side effects, not doing side effects, on treatment, off treatment, just having impact on their life. And I think this is becoming very important. And the patient groups, as I'll show you in a minute, are starting to push that us. And I think as physicians, we are starting to note this. We've done damn well at looking at how to monitor the disease and how to treat the disease, but maybe we haven't done so well in how we treat the patient. Why is it important? Well, let's look at CML therapy in the real world. And much of the world out there doesn't have the resources that those of us are blessed to be in countries that have molecular testing and all the drugs available. But some of these do occur in the first world as well. We've heard that you get out in some of the communities away from academic centers that specialize CML, and the care is not what we think it should be. And there are issues with just drug availability, monitoring availability, using it correctly, and access to healthcare providers, particularly in the third world. You know, if you're in India and get a diagnosis of CML, you may be diagnosed very well, but if you live in rural India, you may be given your package of imatinib and sent off and never seen again. That's something I think we have to do something about. Why? Well, the Swedes showed this a number of years ago, and I bring up this slide all the time. Since imatinib came in, the life expectancy of a Swede from their registry is virtually the same as the Swede of the same age, regardless of what age they were diagnosed with their CML. What is this telling us? Well, it's telling us we're doing well. And secondly, it's telling us is we're never going to do better in terms of survival than we were in imatinib. Unless the drug companies come up with something that has an immortality side effect on their pill. We've done it. So anything else is just, rearranging the deck chairs and getting to the same thing maybe a little faster, a little differently, maybe affecting the side effects a little, but survival is virtually the same as an age-matched control. This is a study from MD Anderson which really showed that we are preoccupied with the depth of response, but this is a 10-year follow-up looking at whether you had a 2-log or a 5-log reduction on imatinib. And if you take a look at the survival after 10 years, which is the end, there's not much difference in the survival of patients. In fact, there's about 5% variability at 10 years. So you do very well, even though you do get the best response. So although the gold standard is TFR, not getting TFR is not a failure. We also know attempts getting TFR, this is from a review published a few years ago, showed that, for every 100 patients that get diagnosed with CML, you maybe have a quarter to a third who may have a successful TFR. They don't meet the standards for trying it, they don't want to do it, they failed doing it, but we're still going to be left with a lot of people who are still on treatment and they need to be monitored down the line. Now, this is from a most recent study which shows that we do damn well with treatment-free remission, but there are some people who do not do so well. Now, this is an interesting slide that I'm not sure was ever published. this is presented as an abstract. Most of us that deal with any kind of malignant disease, we always see that you have survival curve, but the disease-free survival curve is always lower because some people relapse, but they're still alive. This is a story from CML from the original IRIS study. It's reversed. The disease-free survival curve is at the top. And that is because we find patients are surviving this CML. They're going on to die from something else. So we get down to my very cynical definition of a cure. When a patient asks me if they're cured, I say, I'm going to keep you alive to die from something else. And that's really what it is. And I think that we can't ask for more than that. Okay, so we also need to know in terms of long-term follow-up what is safe very often in the short run. You see in product monographs, which comes from the study, is not necessarily there in the long run. We always need to be vigilant, both for cases of relapse, whether on or off therapy, for adverse events, which may develop late, and for psychological issues, which is something we pay very little attention to. I've got one patient who's 20 years after diagnosis has had a successful TFR for 10 years, and she still cannot get over the fact that she had CML. So this is just something, I don't know if you've seen this, we published this a couple of years ago, I'm not going to go into it. We spent a long time, a couple of years, going over side effects and adverse events with tyrosine kinase inhibitors. It took us a couple of years to put this together. This thing reads like a telephone book, if any of you are old enough to know what a telephone book is. But it's pages and pages and pages. But you can find most adverse events there. Many of them are not there in the product monograph because they develop late. So what are patients looking for? And I think this is important. This is a patient that was done in CML, American Canadian Perspectives. They included that the issues that meet important are quality of life. And this is a study that was published by Chris Hillis, who's actually sitting in the back here, that showed that that was very much foremost on patient mind. This was published a few years ago. More recently, this was this abstract that was presented at EHA the year before last, hasn't been published yet, which a group of individuals, physicians and patients, will look what the needs are. And this is where it gets very interesting. If we look at the different patients, what they want, it's very different from what physicians are looking for. Physicians have their numbers. Patients, quality of life, disease progression, getting on with what they want to do. I'm going to skip over that. And it shows that these things change with various things. And there's a lot of dissatisfaction with some of these things with patients, a lot of satisfaction with some things. But basically, they want to get on and live a normal life, whether it's work, play, family, education, whatever. And just, they do show in their quality of life that they do have issues, even when they're doing extremely well. And this study has actually involved a lot of patients who are well motivated. Let's skip that. Okay. So issues with the study, I think it's significant, but the fact that I think this is a well-motivated group and it doesn't really hit the grassroots patients who we never tend to get to. They understand the meaning of the results that are out there, where a lot of people, well, there's a lot of physicians in the community who don't understand what an MMR or the whole, how you get a normal result with that. Most patients just want a normal life, and they want the best outcome. Not as defined by us, but was defined by them. So we need to deal with them differently, like we need to deal with the 4 sons that I said earlier. This means explaining things in a different way, emphasizing different endpoints, continue to ask issues about their clinical and social, cultural, and financial issues and how that impacts, reinforcing things on a regular basis. People get cold, but they need constant reminders. And what's not a problem today may be a problem a year from now when, for instance, they've lost their insurance and now they suddenly have a financial burden. As leaders in the field of CML, we continue to do research. We must do what we're doing with molecular and new drugs, continue to reduce the adverse events that we're having, consider the economic aspects of what's going on. There are vast price differences in the price of drugs out there. And it's not just the cost to the patient, but the cost to society. We must advocate for social responsibility and where to place this in doing it. We must continue to make sure the most accurate data gets out there and communicate with the patients. And how we explain TFR to patients. And the fact that failing TFR is not failing. It may not have the gold standard, but you're going to live a fairly normal life. Perhaps you're taking the pill. So now we have to switch to making sure that they don't get side effects from those pills. So I want to thank a number of people over the years who have helped me. First of all, the patients. Without them, who worked with me, listened to me, chided me, criticized me, kicked my butt on occasions. But with them and their families, in terms of their compliance, and also those, and some of them are here, who helped educate other patients. I think patients learn a lot from other patients, and God bless them for those who are willing to take the time and do that. They give them support, they give them education, where a patient may not listen to me when it comes to support, but they may listen to someone who's gone through the problem. Secondly, to my colleagues, whether physicians, nurses, pharmacists, others, who worked with me for the best thing in mind, which is best care of the patient. And those in pharma in particular who've helped me over the years, helping generate ethical studies, allowing me to participate in some of the studies. In Canada, we rarely left those studies. With pharma, we don't know where in Canada. One we're with the United States, then we're with Europe, then we're Pan-Pacific, then we're with South America. So we never seem to fit in depending on it. But it helped educating patients, healthcare workers. But most of all, to my family. Starting with the boss in the middle and my kids and grandkids around the outside who stood by me during my periods of ups and downs and tirades and everything else. And thank you very much for them being there. So someone was asking the other day, we need a statement as to where we need to be with CML. Now, everybody counts or nobody counts. There is a series of detective books out there, if any of you ever read them, by Michael Connolly. And it's about a police detective named Harry Bosch who actually deals with cold crimes, crimes that haven't been solved. And his motto is, everybody counts, nobody counts. He is there digging into trying to find a solution, even years after everybody's given up. And I think he applies that statement to the crimes. I think this applies this to our patients. Everybody counts. We just don't emphasize the TFR patients. We emphasize the long-term patients. We emphasize the patients with side effects. Harry, this detective, actually developed CML after radiation exposure and is on treatment through a series of these novels. So it's actually very interesting. Perspective reality. Here's a great statement, and I think Jerry Radich, if he's around, knows about. There's a retirement dinner for Don Thomas. Many of you may not Don. He got the Nobel Prize for transplant a number of years ago. And he was being talked to by George Santos from Johns Hopkins, another person out there, and was asked by Fred Applebaum, who's recently written this book called Living Medicine, which is really wonderful for to read. But he asked us, what's it like to work with Don? And the answer was, unless you're the lead ranger, the view is always the same. And I think that's very important. I have the pleasure of working with many of these individuals, and trust me, I've learned one thing. Rudolph can't hold the sled alone. But to me, the view from reindeer was always the same, and occasionally equine view was much the same as well. And with that, I'd like to thank you. And if people want to get a hold of me, there's my emails. And thank you very much for this wonderful honor.